So we have developed questions to guide panel discussion. We have big 4 questions that we would like to discuss over the next 60 minutes. Scott will help us, and he will be assisting us to make sure that we call on you to provide comments throughout the session. And if you would like to comment on each question, please raise your hand. And can we start from the first question? So this is the first question that we would like to discuss. We would like to discuss the ability of currently available abuse-related data resources to adequately characterize the underlying population of those who misuse and abuse drugs. So we would like to discuss how well do they capture the existing data resources, capture occasional and recreational use in severe advanced opioid use disorder. And we also like to discuss how well these resources capture the individuals in between these 2 extremes. So who would like to begin the discussion?
Sid Scholl, I think these questions are nice, but I'm concerned that we're trying to do too much with these formulations. And early on, we were told that these formulations are designed to reduce insufflation and injection. And now we're trying to show that they do everything else in terms of addiction, abuse, overdose. I mean, it's nice, and I think it's important, and having worked in addiction, as I said, for close to 50 years now, I think we need to address the problem of addiction. But these products don't do that. They are designed to simply reduce insufflation and injection. And we have to look at that very carefully. And I think designing studies that will address those specific points are very important. We have seen, unfortunately, that the introduction of these products, along with all the other measures such as PDMPs, public information, etc., has in fact reduced the prescribing, as you've shown, but has resulted in unfortunate consequences as people have shifted over to illicit products. Is that an outcome that's positive or negative? Now, I think we have to look at this in a somewhat different way, and I think your questions are reasonable, but are they really the questions to address by the FDA for these specific products? And I'd like to throw that out.
This is Marc Levenson. Could you elaborate what questions you feel might be more relevant for FDA to address?
Well, I think I did. Let's look at, do these products, which are designed specifically to reduce 2 things, insufflation and injection, do they do that? How effective are they in doing that? We've certainly seen in the category 1 through 3 studies that in those controlled situations they seem to work. But are they working really in terms of once they're in the marketplace? If we can show that, I think that's extremely important to look at. These other things, they're very important, and problems we've been trying to deal with in addiction for as long as I've been dealing with it, and going back even further. But I'm not sure we can do that with these products, and trying to ask them to do things beyond what they are designed to do creates a distortion of what's going on. And I don't think that's what we want to do.
So this is Judy Stephan. Could you connect that? I think that's a very reasonable proposal. Connect how do we evaluate these products and how well they deter insufflation and injecting using the kinds of populations that we have available to us. Where should we be looking at that? I think what we're trying to do is tee up, is that something reasonable to look at in people who might answer household questionnaires, or is that something we should be looking at in people who present to treatment, or people who call poison control centers, et cetera?
Well, I think we've got some data on that from treatment centers. I think as we look at such as the SCIP program from the RADAR system and the NavaPro system, we see that people have shifted away from the injection and insufflation of these products. So there are some data that are currently available, and I think we can continue to look at that and think about potentially other sources. But again, we have to look at what these products are designed to do and study that, not ask them to do more than they can do.
Dr. Cassidy?
Hi, I think Dr. Scholl raises a very good point about the questions being broad, and I think that the questions that you've laid out here, they're important to answer, and they're an important part of the discussion, but I'd like to just maybe follow on with a comment about how we can think about framing some of this as it relates to the question of ADFs versus prescription opioid abuse in general. I think that there's really kind of thinking about it in two tracks, and this might be skipping ahead a little bit, not talking about data sources specifically, but the outcomes all across the board are important, but maybe there's outcomes that are more important in sort of that broader population, prescription opioid abuse, track and path to think about versus outcomes that are more, specific to defining success of the ADFs themselves. And maybe since, there's a number of ADFs currently, or products with ADF labeling on the market, but more are coming to pass, that there's sort of a larger, momentum that they need to have as a group to be able to then make an impact on those overall broader trends. So if we're sort of talking about ADFs, I think we need to think about those specifically and how we term those, and the outcomes and the data sources for them, and and what their success can be, as opposed to the larger, broader. And I think that those are important too, but I think we have to maybe sort of frame them as maybe proximal and distal types of efforts.
Oh, thank you.
We've got several. Dr. Green, you have a comment?
Yes, thank you. I really appreciate the, illustration of the mosaic approach, because there are many different outcomes, and we've listed even here many different populations. But I think, if we think of it in terms of Dr. Snoll's comment about the route specificity and then data systems with product specificity, and focus on those as the most potentially valuable ways to evaluate the impact of ADFs on those specific routes, then, a couple of the things mentioned, like the poison center utilization. In some preliminary work we've done, we've seen that the utilization of poison centers over time is dependent upon the pharmaceutical or non-pharmaceutical aspects of products. So when we look at pharmaceutical products specifically, calls to poison centers, the change over time has been primarily in pediatrics and not necessarily in the adults. And we've seen that utilization has stayed pretty stable in the adult population, which is what we're studying here. So more work can probably be done to understand the impact of poison center utilization, to Dr. Cornegay's point of one of those considerations when we're looking at trends over time. And then also for the treatment center data, looking more at the relationship of, what do those patients represent, what do those sites represent, so looking at comparisons with the NSATS registration data and trying to get a better feel for that representation. I think more work could be done to do that, but really maybe focusing on those programs that have product specificity and route specificity, and then working through some of those unclear questions. We don't know if they have an impact or don't, because we just don't have the information on them. So I think there's some opportunity to do some work in that area.
Dr. Krebs, followed by Dr. Boyer.
I appreciate the comment about what these products actually can do in terms of preventing insufflation or injection as being really the focus. But ultimately, is that important from a patient health and a population health perspective in isolation, and whether the value of the products can really be assessed by simply focusing on their effectiveness in preventing insufflation or injection. You know, we all have seen in this area how unintended effects of a product can have a huge effect on patient health, on population health, beyond the focused, narrow initial indication. And so I think for that reason it's really important to think about how, even if they are effective at their intended target, how they may or may not improve or even worsen population health, patient health. More broadly, we need to evaluate the broader outcomes in addition to the specific focused outcomes that they actually are intended to address.
Dr. Boyer?
Yeah, thank you. I mean, I'm still focusing on the questions that are, you know, like right here in front of us. You know, talking about recreational and occasional use, I don't know that there are a lot of resources that necessarily will pick that, because I think a lot of that, literally by being occasional, is by happenstance. So you're back to a poison control center model for at least acute exposure to things. I'll come back to that in a second. For severe and advanced opioid use, yeah, I get that a lot of people go into treatment, but in chronic pain populations that I encounter who come in and demand opioids, the response then a lot of time is, I don't have an opioid use disorder, I have chronic pain. And just as diabetics need their insulin to survive, I need my narcotics to survive. So they view it as an honest-to-goodness medical problem rather than a potential medical problem which has gone off into a psychiatric tangent. Either way, if somebody in my world comes in with an overdose, we actually did this data in our treatment sites. So this is the major, you know, referral center in central Massachusetts. We demand that the clinicians call the toxicology service with overdoses so that we can keep track of numbers. So we know that because we can compare actual patient presentations with number of times we get called, and this is where we're demanding calls. So that's a surrogate for a poison control center call. We know that fewer than 7% of opioid overdoses who present to the ED actually generate a phone call for toxicologic consultation. You're correct, it's mainly in the pediatric population because there are no clinical data which predict what an opioid overdose looks like in a toddler who just has normal exploratory behavior and happens to pick up the methadone pill. So I don't know that we can talk then substantively about what, you know, about numbers that pop in because the calls are simply not coming in. An opioid overdose is the simplest of all overdoses for a clinician to treat. You give naloxone. If the naloxone fails, you give more. If more naloxone fails, you intubate. And at that point, you've not only done the procedure of intubating, but you've got a patient disposition. When an emergency physician has a patient disposition in place, the thinking stops. So, you know, I don't know how well you're going to be able to capture the acute and recreational. There's some problems with severe and advanced opioid use disorder, and I can tell you that the acute exposures, at least, are going to be extraordinarily problematic to pick up.
So thanks. I just wanted to echo what Dr. Krebs said, that I think you have to look at this in the broader public health context. I mean, we don't want to have industry investing a lot of money in developing products just to show that in isolation they can do something, but in the broader sense we don't get a public health gain. I think the other potential risk in looking at just injection or insufflation is that you're potentially not taking it in the context of secular trends. We know from data sources, from Ted Cicero and others, that people, you know, some proportion of people went from injecting to using OxyContin orally. And so we have to account for those things and changes in trends. And the fact that the vast majority of opioids on the market are not reformulated, so people can easily switch. So is it a question of the product is really good at deterring abuse, or there's just so much else out there? So I think you really do have to take it into that context, both specifically, even if you're looking at injection and insufflation, but also trying to look at the outcomes. And the other thing, I do appreciate that you guys put time into asking these questions and developing them, so I want to respond to the specific question. I think, you know, in the NISTA data, you can get, you know, frequency of misuse or frequency of non-medical use, and we've done a couple of studies looking at the characteristics of people who are more infrequent users versus those who are more frequent, and we tend to see, the use disorder side more in the frequent misuse side, and you can look at other sociodemographic characteristics of those individuals there. I think the big gap is that we have household surveys, so NISDA are monitoring the future school-based survey, and then we have treatment, whether it be TEDS or parts of radars or Navapro, but we know that the vast majority of people who meet criteria for use disorder don't get treatment. So we have a gap in what do those people look like compared to those who are showing up in systems where people are getting treatment? And even if you say, well, use the NISDA as the basis for people who did or didn't get treatment, we still have a gap of probably some very high-risk populations, incarcerated people, people who are homeless, not living in shelters. So I think we have a gap in understanding that group. With the NISDA data, because it operationalizes DSM-IV criteria, you could look at the specific abuse or dependence criteria that they meet to look at a spectrum of people. I think some people have done that with NESARC data as well in a recent paper. But I think it is a gap in trying to understand, who is the affected population, how do they differ. As we move towards outpatient care with buprenorphine or Vivitrol, I think that will introduce another gap where ASI-MV or Navapro, other things may not be in those offices. And again, that population may be different and respond differently to different products that are marketed.
Dr. Sharman?
Yeah, I think the other thing we would need to measure that we don't currently measure is that these ADF products, we're not going to be able to show that they work if people aren't buying them. And I think right now we have a pattern where the ADF formulations aren't designed until that product's about ready to go off patent and it's available generically. So from a cost perspective and insurance reimbursement perspective, they're not going to buy the ADF formulation because there's a modified release product out there that's much cheaper. We saw that when Suboxone and Subutex came on the market. And I note that the ADFs listed in the examples, none of them were ones that contained naloxone. And one of them was supposedly abuse deterrent naloxone. You could inflate it or inject it, and that was supposed to be what was preferred after the initial trial of use. But it was never dispensed because it was too expensive. So the one without the abuse deterrent, the naloxone, was cheap. Hospitals couldn't afford to buy it, and people couldn't afford it, so it was never used. So I think we have to measure what inhibits use at the beginning, and did that ADF formulation, was it so good that no one even bought the product? So I think if we're looking at other data sources, or anybody surveying the physicians, like family practice, internal medicine physicians, and pharmacists, to find out what are their patients asking for. So just for example, at a pharmacy, if you talk to pharmacists, if the doctor writes for a fentanyl patch instead of Duragesic patch, the patient picks. And they'll pick the gel matrix formulation every time. And they'll come up with some excuse why they don't want the non-divertible, where they can't suck the gel out of the patch because they say it doesn't stick. And so, or you'll go to a physician, what are the patients asking the physician for? I mean, I've yet to see a paper that describes anaphylaxis to naloxone, and yet they'll tell their physician, oh, I'm allergic to naloxone, it gives me a headache, I can't have it, so the physician will prescribe a form of the drug that doesn't have naloxone in it. So I think we have to get, or what are patients asking for their physicians for, and are they specifically asking for a product that for some reason wouldn't be abuse deterrent, and what are they asking pharmacists for? So maybe if we did those two surveys, we'd find out they work by the fact that people steer away from those products and don't buy them.
Thank you. That's actually a good idea and a novel concept. And also it leads very nicely into our second question, which also harks back to what Dr. Scholl began this discussion with, which is identifying how products specifically can reduce insufflation or injection. And so our second question also has to do with current data resources, and is discuss the ability of current data resources to distinguish ADF opioid molecules and formulations and discuss the ability of currently available data resources for collecting information on routes of abuse. And I understand that there are probably multiple levels of questions. The global question that is, kind of very difficult to get your head around unless you've had a lot of coffee, and also kind of some of the smaller component questions. But at FDA, we are often faced with answering these questions on individual drugs. So despite the fact that we have to consider all of these drugs in a big picture, and that's really what's important, that doesn't negate our need to understand what's going on with specific drug products. So with that in mind, is there anybody that would care to give us their thoughts on how we can identify these specific drugs and these specific routes and some of the data resources that are available to us today? Oh, I'm sorry, Dr. Boyer.
So I'll just fire back a question at you. Do any of the newer formulations have intentionally added tagans to them?
I don't understand what was the term that you used?
Tagans. So if I'm a terrorist and I buy an explosive, explosive have tagan molecules added to them so that you can identify the source of manufacture. So instead of putting an imprint on the side of a pill to figure out where it came from, you add a chemical that can be detected at a later point. Do any of the newer formulations contain a tagan?
Not to my knowledge. I think that is something that our group has thought about in the past, but it would, it gets very complicated easily if you do a visible kind of identification, like a different shape or a different color or a combination. After a while, with so many different combinations, you're going to get some fatigue of I use the little purple one or the round blue one, and people still don't know what they're taking. And there's not always a toxicology or chemical testing that's associated with these events. So if it's a purely chemical signature, then this would still might not bring you much closer to what specific drug was involved, unless it's a very severe event like a death.
Oh, this is Judy Stephan. I just wanted to ask Dr. Throckmorton, are you aware that this kind of technology is used in any drug products? Because I'm imagining there would be a lot of additional pre-market testing on the safety of that for a patient ingesting something like that.
No, we have a lot of work going on around data around drug supply chain. We passed a law a couple of years ago we're implementing and things like that, specifically tagging individual pills. I'm not aware of. Ed, can you see a little more how you'd see that being used? So you could think about it being used in a kind of, I'm going to go after diversion and I'm going to find out who got that pill prescribed to them, and in a sort of law enforcement sort of approach. Or you could see it used in a way to understand better the patterns of distribution of these products from prescribed use to illicit use or something. Did you, which direction were you coming at this from?
I mean, I was thinking about just the isolated, like the point of manufacture. If I have a patient who comes in and I collect urine and I analyze for, I'm just going to make up a molecule here, oxycodone. I don't know which manufacturer that oxycodone has come from. But if I've got 4 manufacturers of oxycodone, each of whom have a unique tagan added to it, I can distinguish if it's 1, 2, 3, or 4. And then it depends how complex you want to get with it. If you had different like supply chains, you could have other tagans added to it, which would go to different regions of the country. And you're laughing because it gets complicated very, very quickly. But in terms of just adding an inert molecule, it's easy to do. It can be something which is inert. There are plenty of inert chemicals that are out there that get added to medicinal formulations anyway. It just has to be something that can be identified. It can just be something identified easily from a biological matrix, and something that has to be eliminated in urine. And truthfully, there are enough of those things out there that, from a from a chemical perspective, it shouldn't be hard to find. I don't do regulatory science, so I'm not going, so I understand that there are complexities which are beyond my comprehension. But at the same time, from a scientific perspective, it's a really simple thing to do.
Can I respond a little bit more to that? So there are some ADF platforms that have ion exchange shells, right, which get excreted in the feces after the active ingredient has been released. And so, as working with some medical examiners in North Carolina, we asked them to see in their autopsies whether those ghost shells were present, to try to understand whether those specific ADF formulations were being ingested. And it was a very low penetration drug, so there weren't, there was only a handful of cases where they could actually find those, and there's gastric motility issues and other things in chronic pain patients. But when you started combining those autopsy physical findings with the toxicology findings from autopsy, there was this discrepancy where there were other opioids that were prescribed, were used, were metabolites, things like that, where we kind of stopped that project because there wasn't a way because there was multi-opioid exposure in almost every patient. So understanding, even with that tag, it was hard to, and it wasn't a tag, but it was actual physical shell, it was hard to understand, whether the mortality was attributable to this, to which opioid or whether ADF or not. But I think it's generally a good idea, but that was one experience we had with trying to figure that out.
Right, and this is Judy Stephan. I would also think in order to be in the feces, it has to be taken orally. So it's not really getting to our point of what else is happening with it, right? So yeah, but it's intriguing.
That was Dr. Dasgupta.
So I would also ask Dr. Scholl, since you started it off, how well do data resources, specifically those that can get to some of the clinical outcomes, identify the effects of insufflation and inhalation, or insufflation and injection, with specific products?
Well, clearly it's not an easy task to do. I think most of our current data come from sources like NaviPro, like some of the programs in radars, where data are collected on how the person took the drug. I think when you're just dealing generally, we've got two situations that I think we need to consider. One is the prescribed drug, and the prescribed drug is in a person for whom the drug was prescribed. How are they taking the drug? Are they taking it appropriately? Are they doing something like Dr. Sharman mentioned? Are they sucking the gel out of the patch? I think it happens. I think it's a very small percent of people who are prescribed the drug who are doing those things. And then we have, the leak of prescription drugs into an abuser population, and that's a harder group to get a handle on. As I said, they show up in some of the treatment centers, but they're not a group. If I asked in this group how many people have hypertension, we'd see some hands go up. If I asked how many of you abuse drugs, we're not going to see a whole bunch of hands go up. It's not a population that generally identifies themselves, and that's a real problem. But I think we can get at that a little bit, maybe with some of the surveys, looking at things like the POMAC, which is being studied as part of the PMR. But that again is in the treatment population, where these events are very, very small. The people who are doing these things to divert the intention of the drug, that's not the treatment population. And I think some of the comments that were made, Dr. Krebs and Chris made about the general population, I think those are important, But again, I get back, you know, what we have to look at is, you know, what are these drugs intended to do? And we've got to understand there is a broader context, but there are a whole bunch of other things that have to be done to address that broader context. And I mean, we could go into that. I just mentioned that many years ago there was a regular interagency meeting that included FDA, DEA, NIDA, SAMHSA, HRSA, to discuss generally the prescription opioid problem. And I don't think that group has met in 15 years. And I think that getting a group like that together, because it is something that has to be multi-pronged. You mentioned the mosaic approach to collecting data, but I think we need a mosaic approach in terms of addressing the issues, because not one agency, there's a limitation of what FDA can do. And I think FDA has to do as much as they can, but FDA can't do everything in this. And so we have to address this in a different way. This is complex. I think we all know that. And so we have to use a broader approach to deal with it.
Thank you. This is Judy Stephan. I wanted to follow up on some of the getting back to the data source issues. Dr. Boyer, you made a comment about, and this is a question that's come up in our internal discussions, about when people come into emergency departments with an opioid overdose or an apparent opioid overdose, that this is something that largely is known how to treat. There's known regimens. This is not like an exotic poison that people might not know what to do about it. So along those lines, I'm trying to understand how to interpret poison control center data, given that if I'm a pharmacist from the good old days back when, you know, you had a kid ingest something and you didn't know what it was, and you called because you didn't, either the consumer called or the doctor or pharmacist called, not knowing how to treat that. Today, where we are with an opioid epidemic, are people still calling poison control centers? Or what fraction of those would be called, or what features of a presenting case would actually result in a call by a healthcare provider?
So regarding the numbers, I'll let the Poison Control Center representative speak about that. Regarding the quality of the data, I think it's variable. Here's an example from my past. I was interested in dextromethorphan abuse, so I pulled up some cases out of our Poison Control Center, and 100% of our cases were coded as Coracetin cough and cold, because CCC is the easiest thing to enter into the computer. So it didn't matter what the formulation was, it was the one that was easiest to enter in a system that is underfunded, who doesn't have sufficient staffing to deal with the potential avalanche of cases that come in. If a field needs to be filled, then the field gets filled, not necessarily correctly. Now, there's some variation around practice sites, but that's what happened in our neck of the woods. I don't know what triggers a poison control center call, at least what the medical literature says. I know that based on my narrow experience as being a poison control center attending for the last 15 years, actually 17 years now, is that it's something that is odd, something that the doctor doesn't expect. It's something that is ill, something that the doctor generally needs help with, or it's just something the doctor wants to be able to say, I called the Poison Control Center, they told me to do it this way, and eliminate medical legal responsibility for a course of action that they're trying to, that they would like to take. The, regarding routes of abuse, sometimes that appears. I don't know that it's a mandatory field in the Poison Control Center data collection system. What I would say is that there is a potential data source which you haven't mentioned, and that's the Toxic Investigators Consortium. And I don't want to oversell this because it's got enormous limitations on its own, but that is a narrowly defined set of individuals who still have a nationwide distribution who are at the bedside, but they do record not only routes of administration, routes of abuse, but also in some cases, depending on the study that's going on, the reasons for which the substance was abused.
Dr. Crane, Dr. Green, Dr. Compton, and then Dr. Hedegard.
Jody, were you going to talk about poison control? Because if you are, I'll cede to you because I'm talking about emergency departments.
Thanks, Elizabeth.
Okay.
Sure. And the other Elizabeth Sherman should also probably weigh in here. But I do want to clarify, most of the calls are actually from the public, not from healthcare professionals in the poison centers. So you need to keep that in mind too, that the public, usually their calls are because this is new or experience for them, not necessarily. Yeah, not necessarily just the treating physicians, which is a pretty actual small proportion of the calls that come to poison centers. And to confirm, the routes are a required field in that database. And I'm glad we're talking about poison center because more work can be done there. A few years ago, we actually looked at the accuracy of reporting of acetaminophen-containing products in poison centers. And acetaminophen-containing products, while they're over the counter, they are complex as well. There's single ingredient, combination ingredient, cough cold ingredients, and there's hundreds of products in the database that poison centers use. So we did look at the accuracy of the recording of that data. Then we did some training in terms of product specific information and looked to see if the accuracy had improved. So 2 points here. One, the initial data showed that for substance field, it's about a 90% accuracy rate, so that was reassuring in terms of the data being accurately collected. And then for exposure characteristics like route is 95% accuracy. So the baseline for, I think, route is probably easier than products, if you think about it, to report. After we did training, two different types of training, one more intensive, one a little bit more passive, we found a significant increase in that product identification accuracy. So I think, and that actually went to like 93% accuracy. So I think some more work can be done to see, again, this is acetaminophen-containing products, but some of the same complexities as we have with the opioids. So we can do some more work in not only evaluating that, what that accuracy rate is baseline, but then also knowing that some of these training programs that can be deployed throughout the regional poison centers could potentially enhance that accuracy as well.
Dr. Compton.
These are difficult questions. Discuss the ability of current data sources to distinguish molecules and formulations. Clearly the answer is no. We don't have an adequate way to do this. And I thought we heard a really interesting concept from Dr. Boyer that might be amenable to research development. And certainly if there were a commercial partner that was interested, that could be a small business innovative research program. It could be very interesting, not just for this field, but for many others in terms of linking specific products to particular outcomes. There are lots of places in health where this could be a useful concept. There was an earlier comment about interagency collaborations, and I would just point out that FDA has been actively leading the HHS interagency collaboration for many years in terms of prescription drug misuse and the opioid crisis, as well as been an active partner in the ongoing interagency collaborations that span multiple government agencies, including the Department of Justice and DEA representation. I actually wonder if there might be room for some additional efforts in the supply side area to inform some of these questions, whether this is drug purchase on the street, value. This was mentioned earlier, but that's certainly a strong indirect indicator of how much overall misuse there is of these. And that is, while we are focusing on insufflation and injection as the primary target of ADF formulations, the goal is to reduce their overall misuse in the community. So I'd be pretty happy if the price went down of all these substances on the street, irrespective of whether we could determine specifically whether it was injection or insufflation that were driving that. I also wonder about internet sources. There's been some interesting papers on internet chats and discussions as an indirect way to get at this. You never know about the base rate and sort of the denominator in those cases, and the tendency for discussions to go in a direction just spontaneously, witnessing all the viral issues lately. The other, I'd like to turn it over as well to Dr. Cicerone to Tell us, are there local studies that might inform this question, you know, about routes of abuse and distinguishing particular formulations and what drug users are actually doing with them? We really struggle to get that level of specificity and detail in our national surveys, and I don't think it's possible. But there are certainly local studies that can say a lot about this.
I guess all eyes are on me. Thanks, Wilson. So I'll just agree with the consensus of it. These are very complex issues. The questions themselves are incredibly complex. I think we all know that we start with and probably end with epidemiological data. Right? Epidemiological data is going to give us the best picture nationally, scope of the problem, the affected population, you know, the at-risk population, et cetera. We do also need to consider qualitative data, particularly around some of these more nuanced questions like route of administration. You're just not going to get questions around mechanism of abuse easily from quantitative surveys. You can do it, but you could just imagine the amount of lag to say, okay, well, here's a new drug being misused in a new way with a new route and a new set of problems, right? To operationalize all that mechanism is going to take quite a while. And then to get the data and to analyze the data, you're talking about years have gone by. Meanwhile, the drug has moved on. You know, the drug using population moved on. So just to answer Wilson's prompt, the idea of doing hotspot studies, if there's a signal in the poison control data or in the larger universe, to focus down. I like the idea of repeated sort of a longitudinal or repeated qualitative inquiry. This could be done with providers. And over the next day and a half, I can get more into some of the details. It's been mentioned so far, the idea of using, of getting to what are providers seeing, what are the patients asking regarding. You know, there's lots of clever ways of finding out what the users, what the patients are getting to that might be manipulative, if you will. What are the providers' concerns? These could be ED providers, of course, sort of folks at the front line. What are they seeing? What concerns are being raised? And to regularly assess a sample of providers would be useful. The work that I do, it goes right down to the street level. I work with users on a regular basis and find out what molecules they're interested, what chemicals they're interested in, how they're using and misusing them. And that's where you get into mechanism. So for example, when we wanted to explain the HIV outbreak in Scott County, Indiana, it was very important to know how exactly extended release oxymorphone was being used in order to get into the mechanism of HIV transmission. Only way you're going to get that is through qualitative data. But I'll suspend the rest of my thoughts because there'll be lots of conversations moving forward.
I actually was going to move over to mortality data, so if there are other comments that are relevant to this conversation, I'm happy to pass for a moment.
Sure, John Brooks. I just wanted to ask a question with regard to the abuse deterrent formulations. Are you also interested in monitoring for the safety of the deterrent itself? Because that's a substance that's being added to these pills. And I'm glad that the segue sort of occurred here because I wanted to bring that up as something to consider in terms of data sources. In the Indiana experience, we learned that the deterrent itself that was being added to the opioid is what really drove the rapid spread of infection. There were aspects of the deterrent that increased the number of times people had to inject each day, so that on average it was 15 injections, and in the extreme up to 40 per day. And that fueled this outbreak. And we were able to detect that because we have good infectious disease surveillance. So I think those kinds of, if those were the outcomes we were looking for, I think we're pretty well positioned for that. But there was the experience with the intact deterrent that it was also associated with thrombocyte, the TTP. the original formulation, not the revised formulation. And I'm not quite sure how, that was classic outbreak detection. An informed consumer, in this case a physician in a clinic, recognized in excess of a number of cases that was unusual. But being able to know, I think what I'm getting at is being able to know in persons who have taken an opioid, whether they are using the deterrent formulation or another, could be very helpful in understanding these sorts of events. And so Dr. Boyer's point, and what that others have raised, this idea of having some mechanism to detect, was the drug, this person taking a deterrent formulation or the standard formulation, could be very useful. I might just add that in formulating these deterrents, those materials go through a lot of testing, I'm certain. I mean, that's not my area of expertise, and I presume that they're not licensed without being proved to be safe. And I wonder if in parallel with that process, there could be a tag added to the deterrent so that it's easy to detect in a urine or a blood sample.
Dr. Lurie had a comment, Ms. Cassidy had a comment, and then we'll come back over.
Yeah, so I'm just going to follow up on what was said earlier about the need for longitudinal measurements. And I think what we're hearing is that many of the existing data sources aren't really able to assess many of the important outcomes, particularly misuse and abuse. And I wonder if this might call at this point for large multi-center prospective cohort studies of different formulations, different ADF opioid molecules. I mean, we've certainly seen in the literature, particularly in cardiology, where you had 30 to 40,000 people who are on ACE inhibitors who are followed for years or more. Why couldn't you equally create prospective cohorts of patients who are initiating ADFs, perhaps follow them longitudinally with audio computer-associated self-interview software to anonymously assess through a CASI many of the questions about insufflation, abuse, diversion, evaluate the providers of those patients, evaluate for hospitalizations, and perhaps even do surveillance for incident infections. And that would allow you in the prior question perhaps to develop definitions for abuse and misuse and to be able to compare characteristics of those individuals. But I don't think that's going to get at individuals who are not prescribed the drugs, but who are getting them in other ways and abusing. But at least you have a denominator of all new users of those particular drugs and formulations who will be followed over time for both quantitative and qualitative assessment.
This is Tamara Meyer. I just wanted to bring up that I like the way you're thinking, and we'll have a session on that tomorrow where we'll talk more about the possibility of doing longitudinal studies and new studies in general.
Yeah, I just wanted to follow on the conversation about do the current available data sources adequately collect route of administration data. And I think that there are definitely some examples where we've seen that we are doing a reasonably good job at collecting route-specific data and even doing that at a product-specific level. I think with some of the treatment center data that we have from Navipro, we've seen the reformulation of OxyContin, and we've seen oxymorphone ER, its reformulation, the expected shifts. Some of the changes that we've seen were expected, and you can sort of continue to think about like, well, to what degree and what extent there may be some misclassification at the product level for like, was that individual indicating that particular ADF product, but you can follow on from the route of administration evidence that we've seen from that treatment center data, and that corresponds with other data for route of administration for some of these ADFs, that we are doing a reasonably good job for some populations. Now that's the individuals entering treatment. It doesn't necessarily capture maybe the misusers, and that might have different challenges associated with its identification, but at least we've seen those changes quickly happen in the substance abuse treatment population, and they do follow some of the expectation of what those formulations were intended to do. So I think that there is some value. I think we can improve that. And just to follow on what Dr. Ciccarone was saying is from qualitative data, some of that internet conversation of, the treatment center data doesn't capture the how does somebody do something to a drug. It just sort of captures whether they may have snorted it, injected it, crushed it, etc. But if there was a new drug that came out with a new route, we certainly use that data to inform what we're using and improving in the treatment center collection instruments. So I think that when we're talking about mosaic, it's not just the mosaic in sort of study design or data sets, but also thinking about the value of different data sets to link together that can improve and enhance what we're already using and doing.
Dr. Sharman, then back to Dr. Hedegaard for the mortality issue.
Just wanted to speak more specifically about the Poison Center data set. So currently the National Poison Data System does collect route, but it's one single route even if it's multiple substances. So one of the databases used by Poison Center is ToxCentry, and it has already moved to a model where, at least in my center and a number of others, we can collect route by drug taken. And that's a model that poison centers are likely to be moving to when it moves to a different platform that allows us to expand data fields that poison centers can export up to the National Poison Data System. Again, that's been an expensive switch, but that should happen by January of 2019 for all centers. And that would increase our ability to add data fields to send up. So route is required, but it's one route for all substances. But we are moving, some centers have moved, and we are moving to be able to collect route by substance. The other thing that is mentioned is about whether centers can accurately code the name of the product. As I think with any database, it's data in, data out. And one of the problems, when you get a prescription dispensed, so let's say the doctor wrote for Suboxone. Like in West Virginia, it's a generic required state. So the pharmacist has to dispense generic unless the doctor wrote brand only. So that pharmacist is going to dispense buprenorphine naloxone. But because the prescription, the doctor wrote Suboxone, what's going to happen on the label is going to say buprenorphine naloxone, parentheses, dispensed for. So even if the doctor wrote for, if he writes Plavix and you get generic clopidogrel, it's going to say clopidogrel, parentheses, dispensed for Plavix. Because brand names are catchy and easy to remember, that is what gets written in a patient record. Whether you're at triage in a hospital, that's what the nurse is going to write in the record, and that's what they're going to call a poison center and say. So part of the problem of what name shows up in a database can depend on state pharmacy laws and what gets put on the label. And as long as labels are allowed to contain a brand name that's not in the bottle, that's going to continue to happen. We typically are similar to most poison centers. So most poison centers have about 30 to 35% of their calls now are from hospitals. So it's not the majority, but it is about a little over a third of the cases. One of the things that we're finding, so we're in West Virginia, a high substance abuse state. We've really expanded our use of lay public naloxone in our state. What we're seeing, because our particular poison center is capturing this offline, so the data isn't going to the American Association of Poison Control Center database, but we are using that database to collect it internally. And what we're seeing is that about 80% of those patients getting naloxone are not going to a hospital and are not calling EMS. So we're now losing about 80% of those cases that are staying in the public and are not necessarily calling a poison center or going to an ER. So we're looking at capturing that data that is currently lost in the system. And unlike just saying yes or no or given, we're using our risk reduction programs at our local health departments. So when patients are coming back to refill their naloxone, we're getting to where the risk reduction pharmacist is asking, so how did you use it? You know, no harm, no foul question. If you sold it, fine. If you gave it away, fine. How'd you use it? And we're finding that the people are actually being pretty forthcoming in what they've done. And so we've started collecting that information, which is another potential source when you have these hubs of naloxone distribution. What we've also seen in this changing dynamic of lay public naloxone use is when people get to the hospital, they're usually revived by then, And what we did in our small study with a 25 patient opiate outbreak that we had in one of our cities was our health department had a chance to look at some hospital data. And what
Dr.
we found
Shimon,
in that,
I'm so sorry to interrupt you, but we are running a little bit short on time.
So just really quickly, what we found is that these patients, when they go to the hospital, are no longer getting diagnosed as opiate overdose. They're getting diagnosed as withdrawal or pain syndrome. And so that pre-hospital use is changing the reliability of hospital data for accurately picking up opioid overdoses.
Thank you. So we're running a little bit short of time, and I know there's several people who are queued in the line, and if you don't get a chance to speak now, again, you can also submit stuff to the docket, and we'll happy to listen to you over the break. But I wanted to get back to Dr. Hedegaard because she had something to say about mortality data.
So I just wanted to mention about some work that is the collaboration between FDA and the National Center for Health Statistics, where we've actually been trying to look at the literal text on death certificate data to look at the drugs that are involved in drug overdose deaths. This work has been going on over the last several years, but we're in the place now of trying to automate that and make it a more routine process. But even though we're able to look for the names of specific drugs out of the literal text data, for about 17 to 20% of drug overdose deaths in the US, the actual drugs involved are not named on the death certificate at all. So clearly, there's a lot of work that needs to be done with regard to educating medical examiners and coroners about the importance of including the drugs that are involved in the death on the death certificate. That percentage varies a lot by state and by type of coroner or medical examiner system in the state. So some states, the drug overdose deaths, up to 50% of their drug overdose deaths, the actual name of the drug is not on the death certificate. Whereas other states where almost every drug overdose death, it's named. We've also used the same literal text methodology to try to look at the route of administration and just see how often is that mentioned on the death certificate on these drug overdose deaths. And it's a very small percent where the actual route of administration is actually named. It's probably less than even 10% of these drug overdose cases. So because of this need, NCHS is working with other centers at CDC to develop some guidance documents for medical examiners and coroners about what types of information would be helpful to include on death certificates so that we can try to capture these key pieces of information that I think would be useful for looking at overdose deaths.
In the next 5 minutes, we'd like to discuss the best practices for measuring and validating misuse, abuse, and addiction. And more importantly, we'd like to hear if there's any additional important outcomes or exposure measures that could be used in the, evaluating the impact of ADF studies.
So I think one data source that we have not fully utilized are information on rates of diversion. So we have basic information on how drugs are distributed and where they're distributed. For example, the DEA collects ARCOS data. We also have law enforcement data on seized drugs. And looking at differential rates of diversion can provide an indirect measure of demand for substances in illicit markets. I think it's hard to do that with price because a lot of these things are ritualized in ways that are not really amenable to change with supply and demand. But demand does tell us something, and that can be determined by looking at differential rates of diversion. The other data source are dark web websites that provide information on how users are utilizing the drugs and what demand is for those for different formulations, and they're quite specific about what drugs are available through those markets. So it's one of these places where we have highly informed users that describe not only what the product is, but also how to use the product. And those are two sources where we can get some sense of what illicit demand for these substances is, and that provides some indication of what is potentially abusable or places where people can defeat the mechanisms.
This is Judy Stephan. I have a question about that. We've seen diversion data, and we're not sure, because again, we're not law enforcement folks. We don't know how to interpret it, because we're a little concerned. What if a community just mounts a campaign, or a local police force mounts a campaign against a particular product? Is that a marker? I mean, does that mean that they would then find more of it, or would they only do that because they perceive a problem in that community? So is it not relevant?
No, there's definitely problems associated with that. I mean, you're not going to mount a law enforcement campaign against a specific product. You might have problems in communities, like in Scott County, where you then have increased law enforcement activity. But that seems somewhat endogenous to the question at hand, right? So if there are more and more hotspots where particular formulations are causing particular problems, and that attracts more law enforcement demand, that tells us something useful. But you're absolutely right. Law enforcement is not randomly sampling drug users. Things move up and down for reasons. But on the other hand, we have large collections of information from DEA or more regional HIDA kinds of information that can be aggregated above sort of these local concerns. So there is some way of detecting it, but you're absolutely right. This is going to be a very vague measure of community demand.
Janaki Bose from SAMHSA, please.
I don't have any specific answer to the question, but I was wondering if it would be useful to define, we had a slide earlier on, what we were talking about when we talk about misuse, abuse, and addiction. When we talk about misuse, are you including even, using longer, using more often, using without a prescription, using it, so those types, so kind of defining what we mean by misuse might be helpful in deciding what kind of metrics we have. And similarly, what is the difference between abuse and addiction? Does addiction specifically link to having a substance use disorder, and abuse maybe having a subthreshold? So I think maybe defining it up front might help us for the next day and a half.
Well, this is Judy Stephan. I can kind of address that, but I encourage my colleagues to jump in. We're kind of stuck because we can define anything we want, but if we're going with existing data systems that are used for other purposes, we're kind of stuck with what they collect. For the purpose of this question specifically, I think we're actually thinking misuse can be used as a general term of any kind of using a product that is not the way it was prescribed to you. But here, since we're talking about, again, as Dr. Scholl pointed out, these drugs are meant to deter specific routes. So it's really getting at abuse done through manipulation of a product in particular ways. So that's the way we have to think about it. And are there ways that we can improve the data we have existing and the way they collect it to be able to answer these questions? And again, tomorrow we'll talk about, are there different ways we could collect data to be able to do that? But today, we're really trying to be applied here, and can we twist these systems that weren't set up to do this at all to answer these questions? Does that help?
Yeah, I think the route of administration is a big thing, because on the NISDA we do have misuse, and we do know how they used it a little bit more frequently. You can cross-tab that with things like sources of drugs and frequency of use, and you do find that there's a connection between all of those different things. So, but it still doesn't exactly answer what you're looking for, and I was just trying to parse that out.
Captain Jones.
So just quickly on the last question, as was mentioned, NIFLS data from DEA might be interesting partnership to pursue with the labs that they work with at the federal, state, and local level, because they have product in hand. So they might be able to look at what particulars. They just typically report out like oxycodone, hydrocodone, but they have a source of that. And looking to explore with DEA whether or not that could be another source of product-specific data, I think would be helpful. I think the other challenge is that we have a proliferation of counterfeit tablets that are largely impossible to distinguish with primarily fentanyl or fentanyl analogs, and I think that's going to throw off all of the systems. So I think there is a very tangible research project that could be done to do drug testing when people are coming in. A study was done in British Columbia where the people thought they were using cocaine, methamphetamine, a variety of other things, and they were showing positive for fentanyl. So for the Navapro folks, some subset of those who are doing, using the ASIMV or whatever, when people are coming in to test them to see what are they actually showing positive for, I think would be helpful. Same for like the OTPs component of radars. I think for validation, ultimately the work that you guys are requiring under the ERLA, I think will be very helpful here in looking at charts, particularly in trying to understand how well claims data matches up with what really happens. If you look at like some of the buprenorphine claims data, there are lots of people getting buprenorphine who have no abuse diagnosis. probably for a variety of reasons. So if you're just looking straight at the claims, it's not going to be all that useful. And we've done, claims-based studies on overdose when I was at CDC, and you tend to get a lot of not otherwise specified in your ICD-9. You know it's a poisoning, but you don't know what it was. And you obviously are very limited in ICD-9 CM codes for specific opioids. So I think there is just the unfortunate heavy lift of validating through biological specimens, what are people reporting, validating with case review and chart review, what's showing up in coded systems. And that I think that's foundational work that has to be done. And even on some of our national surveys, we often get questions back from reviewers on, this is self-report. How do you know that this is reported honestly? And you use the CASI and other things to try to get honest reporting, but there's not a lot of recent work looking at using biological specimens to validate what people are self-reporting.
Thank you.